Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everybody. Today's presentation is about drug treatment of hypertension, and we'll talk about the drugs which antagonizes the renin-angiotensin system. So the main goal of today's lecture is to know what are the mechanisms involved in the action of the renin-angiotensin system antagonist and what are the actions produced. As we know, the renin-angiotensin system, it is a very complicated system which is involved in many physiological functions in the body, especially the cardiovascular system, the immune system. It is also involved in inflammation, and now they said that they have very important functions in the brain as well, central function. The story begins with the polypeptide angiotensinogen, which is be acted upon by an enzyme, renin, which is released by the kidney. Renin, as we know, it is stimulated by different stimuli, including sympathetic stimulation, beta-1 stimulation. Beta-1 agonist will increase release of renin, and a decrease in blood pressure. A decrease in blood pressure will stimulate the release of renin from the kidney, from the juxtaglomerular cells. A decrease in the renal perfusion will stimulate renin release, and a decrease in blood levels of sodium or hyponatremia. All these which will stimulate the release of renin from the juxtaglomerular cells of the kidney. Once renin is released, it will act on angiotensinogen, and it will convert it to angiotensin 1. Angiotensin 1, it will be converted in the epithelial cells of the lungs and the kidney by the action of the enzyme angiotensin-converting enzyme, or ACE, angiotensin-converting enzyme, in the epithelial cells of the lungs and epithelial cells of the kidney. It will be converted to another local hormone, very potent local hormone known as angiotensin 2. Angiotensin 2. Angiotensin 2, it will act on two different types of angiotensin receptor. They are known as angiotensin 1 receptor. This is the most important to us, angiotensin 1 receptor. These angiotensin 1 receptors, they are linked to G proteins, GQ protein, and GQ protein, as we have said before, it will lead to stimulation of phospholipase C with the production of 2-second messenger DAG and IB3. IB3 will increase in intracellular calcium, and as we have said before, increase in intracellular calcium will result in contraction of smooth muscles. Therefore, if this happens at the arterioles, contraction of the smooth muscles of the arterioles will result in vasoconstriction. This is very important effect. So angiotensin through angiotensin 1 receptor will produce very powerful vasoconstriction. In the heart, increase in calcium level in the heart muscles will result in increase in the growth of the heart muscles, and this is known as cardiac hypertrophy, which is very bad effect as well. The angiotensin 1 receptor will act on its own receptor on the adrenal cortex, releasing aldosterone. Aldosterone, as we know, is mineralocorticoid, which will result in retention of sodium and water and excretion of potassium, i.e. increasing blood volume and therefore increasing cardiac output, and in return will increase the blood pressure. Also, angiotensin 1 will stimulate the sympathetic nervous system centrally. So all these effects, they say that these effects are harmful effects. They are not beneficial effects usually. Okay? So angiotensin 2 through angiotensin 1 type receptor will produce mostly a harmful effect by producing vasoconstriction, cardiac hypertrophy, and as well it will stimulate the immune reaction and inflammation. Angiotensin through angiotensin receptor type 1, they will stimulate the inflammation process through, of course, very different procedures. Angiotensin 2 it will act as well on another type of receptor, angiotensin 2 receptor, angiotensin receptor type 2, angiotensin receptor type 2. The mechanism of action of these receptors are not fully understood, but they say that they might act through GI protein, i.e. they decrease the formation of cyclic AMP, and by decreasing the formation of cyclic AMP, they decrease in intracellular calcium. Of course, this effect will produce exactly the opposite effect from the first effect. So, vasodilatation will take place, and anti-growth factor, they decrease hypertrophy in the cardiac muscle, and they inhibit sympathetic activity, and they inhibit inflammation as well. Okay? So, this is the angiotensin 2, which is very active polypeptide, and it is considered as a local hormone or an autocoid. Angiotensin 2, it is metabolized by another enzyme known as angiotensin-converting enzyme type 2. So we have angiotensin-converting enzyme. This is responsible for conversion of angiotensin 1 to angiotensin 2. And we have angiotensin-converting enzyme 2, which is responsible for the conversion of angiotensin 2 to another angiotensin, angiotensin 1,7, and angiotensin 1,7. These angiotensin 1,7, they act on different types of receptors that are known as mass receptors. These mass receptors, through different processes, they will lead at the end to the release of nitric oxide. Nitric oxide, as we have said before, through cyclic GMP, will inhibit muscle contraction, produces vasodilatation, and they produce as well prevent cardiac hypertrophy, anti-growth. They prevent activation of sympathetic activity, and as well they will inhibit inflammation. Okay? So as we can see, there are two antagonistic forces. One related to angiotensin 2. Angiotensin 2, it has a harmful effect on the cardiovascular system. How? By producing vasoconstriction, increasing blood pressure, by producing cardiac hypertrophy, and as we know, cardiac hypertrophy will result, as we have said before, in heart failure. Aldosterone, it will increase the stress over the heart by increasing blood volume, and sympathetic stimulation. All these usually they are harmful effect on the cardiovascular system. On the other hand, angiotensin 1,7 produce the opposite effects. They produce good effect on cardiovascular system. How? By producing vasodilatation and by producing anti-growth or preventing the cardiac hypertrophy and inhibiting sympathetic activity, and as well inhibiting the process of inflammation. Physiologically, these two antagonistic forces, they are usually in harmony. There is a balance between angiotensin-converting enzyme and angiotensin-converting enzyme type 2. There is a balance in the activity between both. Okay? Now, if, for example, angiotensin-converting enzyme 2 is decreased or downregulated, in this case, what will happen? We'll have less of angiotensin 1,7, which has a beneficial effect, and more of angiotensin 2, which has a harmful effect. This pathologically will result in many cardiovascular diseases like hypertension, like cardiac failure, etc. Okay? So these two systems activity, they act in balance with each other according to the body need. Of course, each one of them is under reflex mechanisms through different mechanisms There is no place to mention them here. Okay? So this is the first, the bad way of angiotensin. Angiotensin converting enzyme inhibitor, they will act as well as an enzyme which will metabolize another hormone or local hormone known as bradykinin. Bradykinin, this is a local hormone, an autocoid like angiotensin, and its action is the opposite. It produces vasodilatation. Okay, bradykinin, it has a beneficial effect. It can produce vasodilatation of blood vessel. It is exactly like histamine in its mechanism of action. Bradykinin, it produces vasodilatation. Bradykinin is metabolized by the same enzyme, by the angiotensin converting enzyme. So what to expect will happen? What to expect will happen if we inhibit angiotensin converting enzyme, we inhibit the metabolism of bradykinin. Okay, so this is the angiotensin, renin-angiotensin system. It is very important system. It is involved in many cardiovascular functions and as well as in inflammation and immune reaction. So what are the drugs? Where the drugs which would antagonize the renin-angiotensin system, where they act? They will act, drugs which are used, of course, clinically. Experimentally, they can act at any of these stages. But drugs which are used clinically, they act by inhibition of renin, and we have talked about that. Drugs which block beta-1 receptors in the kidney, like propranolol, we talked about them in a previous presentation. They will inhibit the production of renin, and therefore they will inhibit the formation of angiotensin, all angiotensin. Okay. The other step is by blocking the enzyme, by inhibiting the enzyme, angiotensin converting enzyme, by inhibiting the enzyme. These drugs, they are known as angiotensin converting enzyme inhibitors. Angiotensin converting enzyme inhibitors. Okay, this is the second. Third groups, they are drugs which block the angiotensin receptor type 1. Angiotensin receptor type 1 antagonist. This is the third group. Okay, so we have talked about the beta blockers. We are not going to talk about them again. Today, inshallah, we'll talk about ACE inhibitors, or drugs which inhibit the enzyme angiotensin converting enzyme, or drugs which blocks the angiotensin receptor type 1. Okay, so the renin-angiotensin antagonist, or RAS antagonist, they belong to two groups. First group are the angiotensin converting enzyme inhibitors, and the second group are drugs which block the angiotensin receptor, angiotensin type 1 receptor antagonist. Angiotensin converting enzyme inhibitors, they are a very important group of drugs, and there are many types of drugs because they have very important clinical application. Maybe the first example which was introduced into clinical practice and the prototype for this group is captopril. This is the first group. Then this is followed by tens of prils, including, for example, enalapril, fosinopril, lisinopril, enalapril, fosinopril, and lisinopril. There are many prils. They end with april. Okay, there are many of them, maybe tens, but these are the most important four. What's the difference between these kinetically? Captopril, usually it has a shorter duration of action and it is taken twice a day, while the others usually they have a longer duration of action and they can be taken once a day. Lisinopril is more water soluble and therefore expect that it is mostly eliminated through the kidney. Okay, so these are the first group, angiotensin converting enzyme inhibitors, including captopril, enalapril, fosinopril, and lisinopril. Lisinopril is most famous, as you know. Angiotensin Type 1 receptor antagonist includes very famous examples like losartan. This is the prototype, the very first, oldest angiotensin receptor antagonist, losartan. Candesartan, they are مجموعة, they are known as sartans. So losartan, this is the first, sartans. They all end with sartans. So the first was losartan. It's used now nowadays. Nowadays is limited. There are new groups, drugs. Candesartan, very famous candesartan. Ibrosartan, olmesartan, and valsartan, very famous valsartan, okay? So these are examples of angiotensin receptor antagonists. These drugs usually, they are competitive antagonists. They are competitive antagonists with slow dissociation from the receptor. They are competitive antagonists to angiotensin, but their dissociation from the receptor is slow, and that's why they have a longer duration of action. Usually they are taken once a day because they have pharmacodynamic longer duration of action. Okay? So these are the examples. So how they differ from each other? So what they do on the cardiovascular system? What they do? Of course, both of them they produce vasodilatation because they inhibit the formation of angiotensin II, or they block the receptor. In this case, the muscle of the arterioles will be dilated, producing vasodilatation. Vasodilatation means decrease in peripheral resistance, which means decrease in afterload. As we have said, blood pressure is determined by the preload and afterload. So these drugs, by producing vasodilatation of the arterioles, they produce decrease in afterload. If the afterload is decreased, if the peripheral resistance is decreased, this will result in decrease in blood pressure. That's why these drugs, they are indicated in treatment of hypertension. They are first line in the treatment of hypertension. Why first line? Why first line? Because as we will see, they have very few side effects and their compliance is very high. This is the first. Second effect, they decrease the preload. How they decrease the preload? Because they inhibit the production of aldosterone. And we have said that aldosterone, what does it do? Aldosterone itself, it will cause retention of sodium and water and excretion of potassium. In this case, what will happen? Sodium and water will be excreted, means decrease blood volume. Once blood volume is decreased, that means the venous return to the heart will be decreased. The venous return will be decreased, and therefore the preload will be decreased. Preload. We said the preload is the venous return to the heart. Once the venous return is decreased, that means the preload is decreased. Now, we said that they decrease the afterload and they will decrease the preload as well. They decrease the afterload by producing vasodilatation, and they decrease the preload by producing vasodilatation of the venules, plus they decrease the blood volume, both. Okay? Now, in these two cases, by decreasing the preload and decreasing the afterload, that means decreasing the resistance against which the heart pumps the blood. The heart in this case will work against low resistance. Just imagine yourself when you go uphill. In this case, you need more energy to go uphill. But when you go downhill, you need less energy to walk. Okay? The same thing for the heart. Now, the heart, the preload is less. The afterload is less. So, the heart will work in comfort because the resistance against the heart is low. So, the cardiac output will be increased. Heart performance will be better. The heart will perform better. They say that increase in heart performance. That's why by increasing the heart performance, that means they will increase the cardiac output. They will increase the cardiac output. The heart will work against lower resistance. Its performance will be increased. Its cardiac output will be increased. When this effect is needed, when the cardiac output is low, like in case of heart failure. That's why they are indicated in congestive heart failure. Okay, so anybody will ask you how RAS antagonists, whether they are AC inhibitors or receptor antagonists, they are useful in heart failure. Why? Because they decrease the afterload and they decrease the preload. That means the heart will work against lower resistance. That means the performance of the heart will be increased. The heart will perform better, means cardiac output will be larger, means that it will be used in treatment of congestive heart failure. Okay, so this is the first action of RAS antagonist on the cardiovascular system. They have very important indication in treatment of hypertension and as well in the treatment of heart failure. Okay, a second action and mechanism is their action, of course, as we have said, they inhibit the metabolism of bradykinin. Bradykinin, as we have said before, it produces vasodilatation. This effect of bradykinin is only done by AC inhibitors. AC inhibitors. Angiotensin receptor antagonists, they have nothing to do with bradykinin. Angiotensin receptor antagonists, they have nothing to do with bradykinin. Only AC inhibitors inhibit the metabolism of bradykinin. So bradykinin will be accumulated. Bradykinin itself produces vasodilatation, adding to the effect of AC inhibitors. So the peripheral resistance will be decreased more. Okay? Yes. Okay. Now, this bradykinin metabolism, it will cause stimulation of the respiratory tract, because bradykinin is allergic mediator, so it will cause dry cough. Therefore, inhibition of bradykinin metabolism, which is done by captopril and enalapril and its congress, will result in dry cough. This dry cough is very common. This is very common in people treated with ACE inhibitors. Okay, this usually takes place in 5 to 20% of persons treated with ACE inhibitors. In this case, if the person at the start of the therapy they suffer from dry cough, the therapy can be changed with the receptor antagonist. And so a receptor antagonist, they have nothing to do with the bradykinin, therefore they don't produce dry cough. This is one important difference. So angiotensin-converting enzyme inhibitors, they produce dry cough as a side effect, while angiotensin receptor antagonists, they don't produce dry cough. Okay. A second effect, due to bradykinin, they produce what's known angioedema. Produces angioedema. Well, angioedema means edema in the larynx, which can cause blocking of respiration. This is very dangerous. Edema in the larynx, which can block respiration. This is very dangerous, and this is an allergic reaction usually. It is rare, but it is fatal. It is rare. It takes place in very few number of patients. But if there is any indication of angioedema, ACE inhibitors should be contraindicated. Okay, angioedema is not common side effect; it is rare side effect caused by bradykinin, and if it happens, that means that these patients should never be given ACE inhibitor. On the other hand, the angiotensin receptor antagonists, they don't produce its effect, as we said. Why? Because they have nothing to do with bradykinin metabolism. And other actions, all of them, they have the same effect. So both of them, they share the property of producing postural hypotension, especially at the beginning of the therapy when there is hypovolemia. What does it mean, hypovolemia? Means the blood volume is low, as in when as in the case of using of diuretics. Suppose the patient was under treatment with diuretics. As we know, diuretics will increase the excretion of urine. That means they will decrease blood volume. By decreasing blood volume, they produce hypovolemia. Hypovolemia. In this case, if this patient is given AC inhibitors or receptor antagonist, in this case, he will suffer from postural hypotension. Postural hypotension. Okay, this is very common side effect. In this case, what we should do if the patient is under therapy with diuretic, for example. If the patient is under treatment with diuretic, for example, which causes the hypovolemia, we should reduce or stop the diuretic therapy for at least 1 week, and then we can continue with the diuretic. Okay, so this is the first side effect. They produce postural hypotension, especially when there is hypovolemia, and we said that hypovolemia is due to decrease in blood volume. Second, they produce hyperkalemia. They increase the potassium level in the blood. They produce what's known as hyperkalemia. And this is expected. Why? Because they inhibit the production of aldosterone, and aldosterone, as we have said, it is a mineralocorticoid which causes retention of sodium and water and excretion of potassium. So in this case, if aldosterone is inhibited, potassium will be retained, will be reabsorbed again into the renal tubules, into the general circulation. So this will produce hyperkalemia. In this case, what we should do, we should follow the potassium level, especially after the start of the therapy, at least for 2 or 3 weeks after starting therapy, to make sure that there is no excessive potassium level in the blood, because as you know, potassium is inhibitory to the heart. Okay, so this is the second common side effect of both of drugs. Both of the drugs, they should be used with caution in cases of impaired renal function. Impaired renal function, as in case of renal artery stenosis. Why? Because when the renal function is low, that means the renal perfusion will depend on the presence of angiotensin 2. Okay, now as we have said that when the perfusion inside the kidney, just as imagine this is the kidney, when the perfusion pressure which goes into the kidney is decreased, in this case renin will be activated, and renin will lead to formation of angiotensin 2. Angiotensin 2 produces vasoconstriction, will keep renal perfusion, will keep enough renal perfusion to produce enough renal function. Okay, so in this case, if we inhibit the enzyme or block the receptor, we prevent the angiotensin 2 action, means that the renal perfusion can go to zero. In this case, بيحصل renal failure or acute renal failure, which is very dangerous. That's why when it is used in cases of renal function, when there is impairment of renal function, usually what we do, we ask for the patient to follow up his creatinine level, to make sure creatinine level at least for 2 weeks or 3 weeks after start of the therapy, to make sure that the renal function is okay. Okay, so third side effect which we should take care about is their use in cases of impaired renal function. Why? Because as we have said, when there is an impairment in the perfusion inside the kidney will depend in its function on angiotensin 2 production. If we block the formation of angiotensin 2 or block its receptor, renal perfusion will become so low that renal failure will take place. That's why usually we have to take care of that point carefully. Okay, One of the side effects which cannot be explained is their effect that it can produce hypoglycemia or decrease in blood sugar. These should be taken very carefully in cases of people who are suffering from diabetes mellitus, okay, and they are under treatment with anti-diabetic drugs, okay. So these are the actions and side effects of RAS antagonists, including AC inhibitors and including the angiotensin type 1 receptor antagonist, okay. So the thing I'm going to talk to you about is the relationship between the RAS antagonist and the COVID-19. It has been discovered that the COVID virus or the coronavirus enters the cell through the ACE2 enzyme. We have said that ACE2 is responsible for conversion of angiotensin 2 to angiotensin 1,7. Okay, we said that the angiotensin 2 it has a harmful effect, and angiotensin 1 and 7 it has a good effects on the cardiovascular system. So they said that the virus, especially S protein of the virus, can bind with the ACE enzyme, and through that it can enter the cell. So there are many hypotheses have provided the last few months. And first, they say that these drugs, or RAS antagonists, they produce a harmful effect. Why? Because they found that the antagonist, angiotensin receptor antagonist, as well as the angiotensin-converting enzyme inhibitor, they produce upregulation. They increase the concentration of the enzyme. They increase the concentration of ACE2 enzyme. And therefore, they suggested that by increasing concentration on the surface of the cell, they increase the entry point for the virus into the cell. That means they produce more infection. Of course, this is more infection. Of course, this is hypothetical process. It is hypothesis. It's not true. This is hypothesis, no clinical evidence for that. There is no clinical evidence for that, okay? So this is the first. They said that RAS antagonists, they will produce a harmful effect by the upregulation of the ACE2 enzyme on the surface of the cell, and this will increase the entry point for the virus. But there is no clinical evidence for that. The other point of view, they said that these drugs, RAS antagonists, they have a beneficial effect. Why they have a beneficial effect? Why? Because they said that these drugs, they have protective effect. Why? Because they found the viral infection itself, COVID-19, produces downregulation of ACE2. They decrease the level of ACE2 in the level. As we have said that there is a balance between the activity of ACE and ACE2. ACE, as we have said, leads to formation of the harmful angiotensin 2, while ACE2 leads to the formation of the good angiotensin 1 to 7. Okay? So that's why they said that COVID will decrease the level of ACE2, making ACE more predominant, and ACE will produce more damaging effect, as we have said earlier. Okay, this is the first proof. They have provide enough evidence that COVID can decrease or downregulate the ACE2 enzyme. Another proof, when they used ACE knockout mice. What does it mean, ACE2 knock mice? That means they removed the gene responsible for the formation of ACE2. So in this case, the knockout mice, these mice, they have no ACE2. They have discovered that these mice, they have greater susceptibility to infection with coronavirus. The opposite. When the mice has no ACE2 in its body, the gene responsible for the production of this enzyme was removed. In this case, the mouse becomes more susceptible to infection with COVID-19. That means ACE2 has a protective effect. It has a protective effect, i.e. it protects against coronavirus. Anyway, this is only a hypothetical and it's only experimental findings, and there is no clinical evidence for this, and we have to wait for some years before this can be cleared up by true clinical observation. Okay, that's all about the RAS antagonist. I hope that you enjoyed my presentation. Thank you for your attention. Please don't forget to subscribe to my channel. I hope you stay in peace and tranquility. Stay at home. Don't go out. I wish you all good luck. Wassalamu alaikum wa rahmatullah wa barakatuh.